Let's try this again. All right, welcome to week 4, where we're going to talk about antipsychotics today and schizophrenia, and we're also going to review GAD. All right. Okay, so you said we can give a benzo, right, as needed in the beginning if there's no risk factors for activation or early, increased anxiety from early treatment of SSRIs. What about if they have PTSD? What could you give them for nightmares and flashbacks? That might also help with anxiety.
Like maybe a beta blocker?
You could, but I would
An
use a
alpha
second one.
blocker?
Yeah, like what? That's with a P.
Propanolol?
No, that's
Oh, sorry.
prazosin or
Yeah.
right? So you can use prazosin. Try to kill, like the way I practice, which I encourage you guys to do the same thing, is try to limit the amount of medications and try to get one med that covers as many symptoms as possible, right? This test that I'm having on the midterm, I'm actually going to really emphasize on. I'm going to tell you, like, a patient has depression with predominantly certain symptoms, right? Which med might be the best option based on the profile. You're not going to give someone a med that's obese, depressed, that already increased their weight, right? You're not going to give someone Paxil if they're having depression and they're already overweight. That wouldn't be a good option. Or someone's already having sexual dysfunction and they're depressed. I wouldn't give them Paxil, right? See how you kind of have to tailor it based on your patient? All right. Why? Why is Paxil a bad choice? It's a very strong what? What mechanism does it have? It's a very strong antihistamine, right? That's why it causes sedation, it causes weight gain. It's also very anticholinergic, which is why people have, dry mouth, blurred vision, withdrawal side effects because of its short half-life and the fact that it's also anticholinergic. It's very hard to get off of it, similar to SNRIs. So I usually try to stay away from it. But since it's antihistamine, it might have a stronger effect than anxiety, but there's a balance between tolerability versus efficacy, right? What's better? A more effective med or one they can't tolerate? You would have to ask the patient and see, but for the most part, patients are going to take meds that they can't tolerate. And would you take a medication if you couldn't tolerate it? Probably not. So there has to be a little bit of balance. What else? The only time you would really use long-term benzos is if someone has panic disorder, right? I know we're not talking about diagnosing now, but panic disorder tends to be lifelong, and it sometimes does get better over time. CBT can help also, exposure therapy can also help, but some people really can't function without a long-term benzo. So I've tried that in the past. Probably I've used Klonopin, long half-life, right? Low doses. Make sure I monitor they're not running out early, they're not mixing with alcohol, and if they're functioning. So the only really two syndromes, quote unquote, that long-term benzos might be best in is panic attack, like I mentioned, or we're going to talk about it today, but it starts with a C. It's usually comorbid with psychosis. The hint. Well, Robert might know. You have this animal. You have
Catatonia?
Very good. Catatonia. All right, catatonia. What is catatonia? We're going to talk a little about catatonia. It's very interesting because as our treatments got better, for some reason, catatonia has gotten less and less. If you go back in history, back in the day, schizophrenia, even though it's been around for, who knows, thousands of years possibly, we just never really put a name to it. It used to be called dementia praecox, right? There was someone, a neurologist first named dementia praecox because he was realizing that kids would develop symptoms of dementia at a very young age, right? Dementia is usually an old person's disease over time, right? 60 or older usually. And they were realizing that kids would have those same symptoms, right? No affect, forgetfulness, cognitive issues, odd behaviors. So he named it dementia praecox, which means dementia before you would normally get it. And it so happened that he actually also went to school with a person who, Alzheimer's, Dr. Alzheimer's. He was the one that was named Dr. Alzheimer's, but they also knew each other. So you have the physician who named Alzheimer's, and you also have the guy who named schizophrenia, dementia praecox. I can't think of his name right now, but it's okay. I'm not going to ask you during the test. But as the disease kind of developed and as we got treatments for it, what was the first antipsychotic? Came out in 1952. I think I mentioned it before. Chlorpromazine. Yep, very good. So a lot of our antipsychotic medications are pretty much just built off of the same concept that Thorazine was, which is a very strong dopamine blocker, right? Thorazine is considered a first-generation antipsychotic. So we do have, technically, some textbooks will say 2 classes. You have typicals, which is, the Thorazines and the Haldols and the Prolixins, the fluphenazines, right? And you have the second generation, the olanzapines, the risperidones, the abilifies, which are partial agonists. What is the difference between a first generation and a second generation? You guys read it in the style book. What is the difference? Really? very basic blanket statement.
Like they have less of the EPS
Very
symptoms.
good. And what does EPS comprise of? It's an umbrella term, which I hate umbrella terms, but if you're going to break down EPS, it would be what? There's drug-induced what? Drug-induced Parkinsonism, which is tremors, unsteady gait, shuffling gait sometimes, right? Mask-like faces, they don't show reaction. Now, it's very hard to tell the difference between someone who has drug-induced Parkinsonism, who you're treating with an antipsychotic, a D2 blocker, first generation, versus someone who has really prominent negative symptoms of schizophrenia, because it can look the same, right? How would you know one over the other? How could you figure it out? If you could, what would you do? Get a blank blank. Baseline. Before they're on medication, see how their affect is. Obviously, if there's a flat affect, then it was there before. Or if it gets worsened, maybe the med's worsening it. But if their mood is reactive, they're having more psychosis, not cognitive issues, disorganized behavior, but there is affect there, and now you put them on a strong D2 blocker like Haldol or fluphenazine, like Prolixin, now their affect is flat, then you would probably rule in, I'm sorry, drug-induced Parkinsonism. How would you tell if someone is developing drug-induced Parkinsonism from an antipsychotic medication? What could you look at besides the reaction to their face? What do people do all the time? You go from one room to another. How do you get there?
Walk.
Very good. You walk. And what are some things that we look at when people walk? Their
Gait.
gait.
Yeah.
Okay, besides gait, what else?
Balance.
Okay, balance. Good. What's another one? They use their arms to move, right? Arm swing. Look at the arm swing. Usually the arm swing, think of like when a car's battery is about to die when you have the windshield wipers, right? What happens over time is the battery, like the windshield wipers get slower and slower, right? So you need to kind of keep an eye out. Are they, when they walk, do they have a lot of arm swing? And then a couple of months down the line, you have them on antipsychotic medications. Symptoms are getting better, but now their arm swing is less and less. So it's kind of like it goes from here, amplitude is big, right? To a small amplitude to very small, right? Now they have no arm swing. And now they have no affect. Probably drug-induced Parkinsonism, right? So be aware, because what motor pathway is involved in that movement? By the way, I'm emphasizing the dopamine pathways. You need to know that. There's a lot of questions in the exam about dopamine pathways, right? So please. Yep.
Nigrostriatal. Right?
Very good. Nigrostriatal, right? Substantia nigra to the striatum, which is the caudate putamen, right? That pathway has to do with movement. So when you're blocking dopamine in that pathway, you don't really want to block dopamine in that pathway. Right, it's an inadvertent side effect. So you block dopamine in the nigrostriatal pathway and someone has Parkinsonism, right? Or dystonia. Their neck is stuck on one side, or they have their back is like stiff. Usually affects the back of the neck, usually. So that's affecting nigrostriatal. But the meds, where do you want it to work? You really want to block dopamine in which pathway? The dopamine pathway for antipsychotic effect, positive symptom.
Mesolimbic.
Very good, mesolimbic, right? Which is also the ventral tegmental area to the nucleus accumbens or the ventral striatum, right? I don't know, it's up to you. So know that positive symptoms are implicated in the mesolimbic pathway. Nigrostriatal is where your movement is. So if there's any lack of dopamine there or blockade there, it's going to cause drug-induced Parkinsonism or dystonia. Mesocortical pathway is what impacted during what symptoms of schizophrenia? Negative symptoms. All right, negative symptoms or cognitive symptoms. What about someone has elevated prolactin or hyperprolactinemia? Which pathway would be affected with that? What is TI? He's not a rapper.
Tuberoinfundibular.
Very good. Tuberoinfundibular, right? Which is the hypothalamus connection to the pituitary gland. All right. The old name for dopamine used to be called prolactin inhibitory hormone, PIH, because they used to know that dopamine, when it's high, it actually inhibits prolactin release. So women can't breastfeed, right? Because they don't have enough prolactin. So what happens if someone has hyperprolactinemia for a very long time? What are some of the long-term effects? Actually, Sarah, you should know that. That's your specialty. What do you do if someone's prolactin is elevated for a long time? Or what are the risk for? Yeah. Galactorrhea, right? For a male is very uncomfortable and embarrassing. A woman might have amenorrhea, and they're not going to have their period, right? Long term, it can cause osteoporosis, right? Brittle bones. So you would order a prolactin level. So if a woman's on, I don't know, the meds that cause the worst hyperprolactinemia are actually the dones, particularly risperidone, paliperidone, which is an active metabolite of risperidone, and also the first generation antipsychotics like fluphenazine or haloperidol, right? Very strong dopamine blockade is going to block dopamine in the tuberoinfundibular area, and since dopamine is going to be reduced, quote unquote, what's going to happen? Prolactin is going to go up, right? Prolactin should not be, for a non-pregnant, non-breastfeeding male, shouldn't be above 20. I've had females and their prolactin was like in the hundreds. And a lot of times it's actually not even from the antipsychotic, it was actually a prolactinoma, which is a non-tumorous growth there, right? They can give them dopamine agonists to bring it down or to actually do surgery. It really depends on the neurologist, I guess, right? But I've seen both. So make sure you check prolactin level, especially if a female starts, reporting irregular periods, if they never had it before, and you want to rule out that it's from the medication, all right? Like I said, dopamine blockade or risperidone and paliperidone and Vega are notorious for that. Okay. A technique I use sometimes, I give them a little bit of an agonist, a partial agonist, I'm sorry. So I might put them on risperidone and I might give them a little bit of Abilify, sprinkle it in just a little bit. So my key is that I'm not going to interrupt the dopamine blockade in the mesolimbic area that competes with psychosis, but I'm giving a little bit of dopamine. Remember, it's a partial agonist. It can work two ways, as an antagonist or a agonist, right? Since I'm blocking dopamine in the tuberoinfundibular area, I'm hoping a little bit of Abilify will actually sprinkle in a little bit more dopamine. And if I'm increasing dopamine, what'll happen? Prolactin will go down. All right. Other times, sometimes when I do order prolactin, I do it early in the morning, and things that could elevate prolactin, obviously sexual activity, stress, exercise. So if it is elevated, I'll probably ask them, hey, before we did it, did you do any of these things, right? So if they did, then I'll probably recheck it again, just to make sure. All right. Any questions for that? Know the pathways. All right. Mesocortical is involved in the negative symptoms, cognitive symptoms. Mesolimbic is involved in the positive symptoms, which is psychosis and hallucinations. Nigrostriatal has to do with the pathways, and tuberoinfundibular, like I said, has to do with prolactin. All right. Those are the main pathways you should know. Know the difference between the first generation and second generation. First generation are very strong dopamine blockers usually, so they're at risk for EPS. EPS is an umbrella term, and that comprises akathisia, which means that they're inability to stay still, right? They have an inner sense of, so it has a sensory and a motor component. A sensory component means they feel restless, right? They feel like I can't sit still. Motor component means they have to move around a lot to alleviate some of that. Sometimes they'll describe it as I have ants on my bones, right? I'm constantly moving around. I can't stay still. Sometimes what I'll do is I have them sit in the chair in my office and I'll say, let's do an exercise. I'm going to set my timer for 30 seconds. I want you to try to be as still like a statue for 30. They can't do it. Even 30 seconds, they can't do it. They can't sit still. They start moving their butt. They start moving their feet. They start moving their fingers. And they say, I'm really sorry. I tried my best, but I can't. Right? So that would be akathisia. There's actually called a BARS. It's called the Barnes Akathisia Rating Scale. The Barnes. You could do that also. So it'll rate both the motor component and the sensory component, right? And then you also, of course, you have something called tardive dyskinesia. What is that? It's part of EPS also, but it's different. What does tardive dyskinesia mean? What does tardive mean? If someone says you're tardy, what does that mean? You are
late.
very good. So it's late onset, right? So tardive, late onset dyskinesia, involuntary movements, right? So usually it has to do with people on long-term medications. So it doesn't have to do, so people sometimes misunderstand that someone could be on low dose antipsychotic medications for a long time and still develop tardive dyskinesia. It doesn't have to be very high dose. So it could be sustained D2 blockade over time, even with a low dose. I've seen it with people on Abilify for a long time, right? 10 milligrams, it's a partial agonist, but they've been on it so long, they still develop tardive dyskinesia, all right? We use a scale called the what? Or tardive? AIMS, AIMS, Abnormal Involuntary Movement Scale, AIMS. So you can do an AIMS exam. The interesting thing is, the reason why I don't like to use the term EPS is because some of the symptoms that are under it have different mechanisms, right? Like akathisia is usually norepinephrine driven. It has nothing to do with dopamine. So you can give someone, dopamine and they're still going to have restlessness, right? If it's not restless leg syndrome. EPS, dystonia has to do with not enough dopamine and too much acetylcholine. That's why it gets alleviated by giving someone anticholinergic, right? Like benztropine. Tardive dyskinesia is the opposite. It's a hyper dopaminergic state. I'm emphasizing the hyperdopaminergic state because I want you guys to understand how does a neuron regulate based on agonism or antagonism, right? If you're giving someone an agonist therapy for a long time, what's going to happen to those postsynaptic receptors? Are they going to upregulate or downregulate?
Upregulate.
Are they going to what?
Upregulate?
No.
Oh.
You're giving someone an agonist for a long time. They're going to be so used to too much stimulation, they're going to downregulate, right? It has to go to homeostasis. So imagine you're giving someone Haldol. I'll emphasize that because it's a very strong, it's only a D2 blocker, so it's easy to explain. You're blocking D2 in the nigrostriatal pathway, right? Those receptors in the basal ganglia are going to upregulate and become very sensitive because you're blocking that area with Haldol for a very long time. So what's going to happen is technically with upregulated and very sensitive receptors, that would be considered a hyper increased dopaminergic state, right? Because every dopamine receptor that gets hit by dopamine is going to be increased, very receptive to it, right? Because it's been blocked for a long time. So that would be considered a hyper dopaminergic state. So the reason why I'm emphasizing that is because back in the day, they used to give cogentin, which is anticholinergic, which actually increases dopamine over time for tardive dyskinesia, but actually makes it worse. So there's actually a battle between, anticholinergics and increasing dopamine, which can worsen tardive dyskinesia. So be careful. If someone has tardive dyskinesia, do not give them cogentin. All right, it's going to make it worse. Even there's studies now that show that prophylactic cogentin, which when I was trained a couple years ago, that's what I was taught. I don't do that anymore. Do not give cogentin unless a patient actually has dystonia, all right, or other symptoms that are a hyperdopaminergic state. I mean a hypodopaminergic state. All right, reserve cogentin for someone who has stiff neck, who has Parkinsonism, who has flat like Macy's, who has no arm gait. Keep cogentin for that. If someone has involuntary movements of their mouth, their tongue, do not give them cogentin, right? What's the class of meds you give for tardive dyskinesia? VMAT inhibitors, right? VMAT inhibitors. VMAT2 inhibitors to be exact. VMAT2 inhibitors. Valbenazine and deutetrabenazine. Those are the two classes. All right. I'm only mentioning generic now because I'd rather all the test questions are going to be generic names of meds. So there's valbenazine and there's deutetrabenazine. Deutetrabenazine and valbenazine. Any questions with that? So VMAT inhibitors, they actually decrease dopamine because remember, the vesicle inside of the neuron is what helps recycle the dopamine, right? If you stop that vesicle from reuptaking the dopamine, what's going to happen? It's not going to be safe. It's going to be eaten up by something called monoamine oxidase, right? If monoamine oxidase heats it up, technically you're reducing dopamine, right? You're not going to make enough dopamine, and you're going to balance out that hyperdopaminergic state in the nigrostriatal area, and it's going to bring it down. Does that make sense? Okay, so VMAT2 inhibitors, they stop the vesicles from reuptaking the neurotransmitter of dopamine, and then any dopamine that's not reuptake, it's going to be eaten up by monoamine oxidase, and it's going to reduce the dopamine levels, which will improve the tardive dyskinesia. But if someone has drug-induced Parkinsonism, what's going to happen? It'll worsen it. See the dilemma I'm talking about? Someone can have both. Someone can have dystonia, which is a low dopaminergic state, and tardive dyskinesia, which is a hyperdopaminergic state. So you can't really treat both at the same time. You have to choose one and find out which one is most impairing with the patient. Sometimes you get lucky and you do find a balance, but from my experience, it's very, very difficult to treat both. Because either you worsen the psychosis, you worsen the EPS, or you worsen the tardive. So there's three factors you have to balance in. I'm talking about right now, right? Right now, the treatments that we have are very difficult. Who knows? Maybe down the line, if a new mechanism comes out, you might be able to do it. But just in case 50 years from now, someone else is watching my YouTube channel. I'm talking about June 14, 2024. Who knows what's going to happen back then? Any questions so far? That was pretty meaty what I mentioned. Do I have to explain that again? You guys can watch the video again if you need to, but just know that tardive dyskinesia is a hyperdopaminergic state. Dystonia, drug-induced Parkinsonism, is a low dopaminergic state. Know what happens with upregulation, downregulation? No sensitization, resensitization. So when a receptor downregulates, right, it's reducing the amount of receptors. It usually desensitizes also, right? It's not as sensitive. When a receptor upregulates, it usually sensitized, becomes sensitive at the same time, right? They don't happen the opposite. So either the receptors go up and become very sensitive, or the receptors go down and not be sensitive. All right, make sure you know that. Know the difference between the first generation, right? Because they block very strong dopamine. People are at risk for motor symptoms, right? Dystonia, Parkinsonism. The second generation, even though they have much less, not zero, motor movements, because risperidone can still cause a lot of EPS, like dystonia and drug-induced Parkinsonism. Atypicals can cause a lot of metabolic. right? Any questions with that? So know the difference. If someone's overweight and has a history of diabetes in their family or elevated triglycerides, I would probably stay away from second generation antipsychotics. All right, except maybe specific ones like Latuda or Vraylar or even Abilify might be better, but stay away from. So the meds that cause the most metabolic symptoms are the penes: quetiapine, olanzapine, clozapine. Clozapine is the worst one. It causes the most weight gain. Second would be olanzapine. All right, but we still use clozapine because it's the best med for what? Blank schizophrenia. What is it? What's blank? Sorry, Rob, can't hear you.
Treatment resistant.
And how will you define treatment resistant?
Failing an appropriate dose and duration of 2 meds.
Very good, two. So you would probably do a level, right? Do a level once they're set, make sure they're actually taking it, or even put them on long-acting injectable to make sure they're actually taking the medication. Right? Because patients with schizophrenia are very, or any disease, right? Notorious for poor adherence. And you don't want to disqualify someone, you know, if they really are taking the meds, but you want to make sure you're not giving clozapine prematurely either, right? I'm asking a lot of questions on clozapine because I think it's important for you guys to really be comfortable prescribing it, because it's a very life-saving medication. It's one of the few meds in schizophrenia and psychosis that have shown to reduce aggression and reduce suicides for psychosis and schizophrenia. For mood disorders, it would be what? What's been shown to reduce suicides and mood disorders? Which medication?
Lithium.
Lithium, right? So those are the only 2 meds in psychiatry. Clozapine for psychosis and schizophrenia, and lithium for mood disorders that have shown to reduce suicides. All right, so you really want to offer these to patients, especially if they have a history of suicides. It could be life-changing for them. Clozapine, even though it's been around for a long time, even though it's an atypical, it actually came out like 3 or 4 years after Thorazine, so 1955, around there. All right, what happened was it was used in Europe, and then they realized that people who were prescribed it were developing what? They were dying from it. Severe neutropenia, right? Or agranulocytosis. So their white blood cell count, most of our white blood cells, right, 60% or higher is neutrophils, right? So all you have to really do is measure neutrophils. If the neutrophils start to drop, then someone's immune system is being compromised. So we measure something called the what? It's 3 letters. What's the 3 letters that we measure for? You write it on the script. ANC levels, absolute neutrophil count. All right. If ANC goes below 1500, we usually have to stop the clozapine. All right. If someone has something called BEN, which is benign ethnic neutropenia, then they're allowed to stay on it as long as it doesn't go below 1000. All right. Usually I would rule out BEN by sending them to the primary care, and they can do genetic testing. Usually BEN is people of African or Middle Eastern descent, right? Usually African descent, actually. Ben. Right, so if someone has a history of low neutrophils, they've been okay, asymptomatic, they've been functioning like that, send them to a hematologist or an internist and have them do the test and actually document that they have Ben, because then you can keep them on the clozapine. All right, so usually there's a REM system, which is like a risk mitigation system, which means that they have to, for the first 6 months on clozapine, there's a titration that's recommended. Usually it's like 25 milligrams. Well, outpatient is 25 milligrams for a week and 50 milligrams for a week. Inpatient, you can adjust it every 3 days. All right. But you want to go slowly because in the very beginning, they're at the highest risk of developing severe neutropenia or agranulocytosis. All right. It gets better usually after a year being on clozapine. It actually, the risk gets much, much, much less actually. Why do you think that is? It is a blank response. It is a autoimmune response. So this is an autoimmune response. Your body kind of gets used to it over time. But the problem is if you miss, clozapine has a very short half-life. If they miss more than 3 days, they have to restart the titration, which is a nightmare. So be careful. If a patient is stable and they're outpatient, make sure that they don't miss more than 3 days, right? Because their risk of developing severe neutropenia goes up exponentially. So they have to take it every day, all right? So if they're stable on 200 and they miss more than 3 days, you have to restart it again from 25. And sometimes you have to hospitalize them depending on their past history. If they have a history of aggression or really bad psychosis, you might have to send them back to the hospital to stabilize them again, which is a pain in the ass. All right.
I'm sorry, did you say so you have to go back and start them at the beginning?
Yeah, from the very beginning. Yeah. Someone could be on clozapine for 5 years and they're stable. And now they go on vacation, they forget to bring their bottle. and they come back and they want to start on the 250 or whatever dose it is, you have to restart from 25 again. Look, I'm sure there's people out there that have done it, but I wouldn't risk it.
Yeah.
Just be very careful. So clozapine is a very strong anticholinergic antihistamine, which is why it can actually cause really, really bad constipation. So usually patients on clozapine, I put them on a bowel regimen right away. All right. What is normal bowel transit time? How long does it take for you to eat a sandwich and for it to come out your anus? How many hours? Depends. This is average now. 24 hours. Most people's bowel transit time is 24 hours. All right. You give someone clozapine, the bowel transit time goes up to 100 hours. Now imagine if they're on other meds that slow motility, right? It gets a lot worse. So sometimes people on clozapine, you ask them, when was the last time you had a bowel movement? Are you regular? Some people might say, well, I usually go every 2 days. Okay, since you've been on clozapine, how is it now? I go every 4 days. So usually I put them on Colace, right? Which is a stool softener right away. Once you're on clozapine, automatic, you get a free Colace. Buy one, get one free, all right? Twice a day, BID. If Colace doesn't work, what can we add next extra? What is Miralax? It is what kind of laxative is it?
It's water soluble.
Osmotic laxative, very good. Osmotic laxative, right? So they need to drink a lot of water and it helps force it out. If the Miralax is not working, what can you give them third line? Oh, I'm sorry, not third line. You would add it actually. You keep the Colace, you keep the Miralax, you would add something called Senna, which is an irritant laxative, right? So sometimes patients are very high dose of clozapine, they'll be on all three. And if not, you give them a prostaglandin medication, Lactide, which is very expensive. But if you can tell the insurance company, hey, they're on clozapine and we've tried all these other classes of meds, it's not working, you might have to. All right. So Colace, Miralax, Senna, Lactide if they have to. All right, make sure they're moving the bowels because the really most dangerous side effect of clozapine is not even neutropenia. The risk of neutropenia is not that high compared to others. Myocarditis is also a risk factor, but it's not that high. The risk factor is actually paralytic ileus, right? People don't have bowel movement, they shut down their bowel and the poop just sits there. Do not give them bulk forming laxatives, all right? Because what's gonna happen? Give them Metamucil and it's not moving, you're making cement, right? All that shit is just gonna stay there, it's not gonna come out, it's gonna get worse. Do not give them Metamucil, no bulk forming laxatives, all right? Irritant laxatives, stool softener, right? Osmotic laxatives, that's it. No bulk forming laxatives. Any questions? Clozapine has a level, it's between 350 and 700 usually, all right? Most labs will have a different parameter, but I've had patients on 1,000, their level's been 1,000, they're stable, I just document it, right? There are some treatment-resistant patients that have been in state hospitals and they're on very high doses of clozapine, yet their neutrophils are fine, they have no risk of seizures, no risk of heart problems. I keep them on that, I document that their clozapine level is 1,000, they're okay, all right? Know what interactions might increase and raise clozapine. So clozapine is a substrate of what CYP enzyme? 1A2. 1A2. All right. 80% of it is 1A2, 20% is maybe 3A4, 2D6, give or take. But 1A2 is majority of the metabolism of it. So what are some 1A2 pharmacokinetic interactions? Cigarette smoking. Smoking, by the way. Not
Caffeine.
just cigarettes, marijuana smoking, right? So the aryl hydrocarbons, when someone inhales it, it induces, it makes your body create more 1A2. So that can actually, will that increase or decrease clozapine levels?
Decrease.
Decrease, right? Because you're increasing 1A2 and it's going to bring down the levels, right? That happens a lot. Patients are hospitalized, they were smoking, you can't smoke in the hospital. Now they go out and they're discharged and they start smoking and you do a clozapine level and don't assume that they're not taking it. They probably are, they're just smoking cigarettes. So what do? You do a level and you adjust it accordingly. All right. What about if someone drinks caffeine? What does that do to clozapine level? That's a 1A2 inhibitor. What's going to happen to clozapine levels?
Increase.
It's going to increase. Yep. Very good. So if someone wants to drink coffee, just tell them to balance it out with some cigarettes, right? Isn't it easy? So things that might induce 1A2, broccoli, a lot of broccoli. So if someone's a vegan, they drink a lot of like cruciferous vegetables, actually, broccoli, cauliflower, that can induce 1A2 too. So, I'll probably just do a level. If someone wants to change their diet and they're stable on clozapine, I'll usually say, hey, what kind of diet do you want to do? All right, and we'll work accordingly to balance out your levels. All right, but it can be done. Sometimes, inhibiting, so if someone has a clozapine, so I told you 350 to 700 usually the cutoff, right? Usually if you go above 650, 700, people are at higher risk of developing seizures. So usually we might add something like Keppra or levetiracetam or Depakote, right? Depakote is a broad spectrum anticonvulsant. We try not to use Depakote. Why? What does Depakote do that can worsen with clozapine? It suppresses what?
Bone marrow?
Very good, right? So you're suppressing bone marrow and you have a med that also can cause neutropenia. It's not a good combination, right?
Mm.
So look, we do it. I've done it, but just make sure you do a CBC more regularly if someone's on it. All right. It's always a risk versus benefit, and you document that. Patient has a risk of seizures, has had a seizure. You know, Depakote is broad spectrum. They're aware. We do CBCs pretty regularly, and we'll make sure that it's normal. All right. If you're worried about that, you can use Keppra. But don't start Depakote prophylactically with clozapine because the risk of agranulocytosis goes up a lot more. All right. So be careful of giving someone clozapine, Depakote, and carbamazepine. They both suppress bone marrow. Right. The difference with Depakote is it's a histone deacetylase inhibitor, like I said, so it's not autoimmune. It can happen anytime. So someone could be Depakote for 10 years and all of a sudden they develop, bone marrow suppression. We don't know why, it just happens.
Mm.
At least with clozapine, it's autoimmune, so usually your body adjusts so it gets much less, right? So usually the 6 months, for the first 6 months on clozapine, they're doing weekly blood work. After 6 months to 12 months, it's bi-weekly, and then after 1 year, it's 1 month. You just do and in Europe, they don't even do monthlies anymore. They got rid of that because they realize that the risk after 1 year is so low to catch them having severe neutropenia at the same time every month is not even, doesn't make any sense. So you do have new point of care systems now, which they have a finger stick machine. One is made by a company called Athelis, which you can do a finger stick and it'll give you ANC right there, point of care testing. So you don't have to send them out to do, CBC could take a couple hours. They have to get the full blood work, right? Who wants to get stuck all the time? At least a finger stick is a little bit more convenient for them. All right. Bowel regimen is very important. Seizure risk. If someone's developing chest pain, all right, you would do troponin I, CK, and CRP to rule out myocarditis. Okay. Troponin I, CK, and CRP. The reason why we do CRP too, because sometimes if we do troponin and CK, there's a certain subset of patients that will have abnormal CRP and you're not going to catch the myocarditis. So you have to do CRP also. CRP is an inflammatory marker, all right? Sometimes with depression, some patients might have elevated CRPs also, C-reactive protein, all right? Okay, know about lithium. I know we talked about it a couple weeks ago, but there's a lot of questions on lithium. I want you to know the values of what the normal value of lithium is, which is 0.6 to 1.2. Remember, I said half a dozen to a dozen, right? So lithium levels, 0.6 to 1.2 millimoles per liter. Thorazine, nanograms per ml is 350 to 700. Depakote is 60 to 120. Carbamazepine is 6 to 12. All right. Look, the book might have a little bit of a different level, but on the test, it's going to be close to that. All right. So the book might say, I don't know, 0.6 to 1.1, right instead of 1.2, whatever. But it's going to be close to that. Most labs are a little bit different, but it's pretty understood that, that they're close to each other. All right. What else? Oh, the pathways. All right. Catatonia. So catatonia has two components to it. All right. It can be stuporous catatonia, which everyone sees in movies where someone's not moving, they're not talking, they're pretty much like, their eyes are not moving, there's no blink reflex, and they're pretty much waxy. Waxy means you can bend them and then they stay there, right? Sometimes I've had a patient become catatonic getting out of bed. So he was actually, when you get out of bed, you put one foot down and you're about to put the other foot down. He became so catatonic, he put one foot down, and before he could put the other foot down, he was stuck like that, like a statue. So the thing about catatonia is they go against, it's amazing. You go against gravity. He was balancing all his weight on one foot, while one foot was still partially raised and he was leaning back. I can't even explain it. It was amazing. He stayed like that for 20 minutes. He wasn't faking it. That's catatonia. And you tried to move him and bend him, and you could pretty much pose him like a wax figure, right? So what do? How do you treat catatonia? What's the first line? A blank.
Anticholinergic?
No. Ativan, lorazepam challenge, right? You give them Ativan IM. All right. The reason why we do IM is because if you give them PO, it's not going to reach a peak concentration. It's not going to be enough to subvert the catatonia. So we usually give them IM. The amazing thing about it is usually within like 5 or 10 minutes, they'll start walking again, they'll start moving again. But then what happens? Once the Ativan is leaving the system, the catatonia comes right back, right? So usually what we do is we put them on like Ativan 3 times a day, right? They'll stay on it for a while for maintenance treatment. And there's another part of catatonia called excitatory catatonia, which someone actually does the opposite. They'll have like purposeless movements. They might have something called echolalia, where they repeat everything you're saying. Echopraxia, where they'll follow you, do everything that you do. It's very interesting, right? They'll have something called negativism, where you ask them to do something, they'll say no for everything, right? And you'll say, shake my hand. You'll see videos of this on YouTube. It's called negative. They go to shake your hand and they'll pull away. And you say, okay, let go of my hand. They won't let go. You want to get out of bed? No. You want to take your medicine? No. You want to see your family today? No. Everything is no. All right. So echopraxia, echolalia, purposeless movements. We had a inpatient where he would every like half hour he would run out of his room and he would jump up and smack the exit sign in our unit and he would break it. Every time maintenance came to fix it, he would run out every half hour and he would smack and he would break it. Right? Purposeless, no reason for it. We gave him antipsychotic medication. We thought he was psychotic and he was delusional. That's what he was doing. Didn't do anything. It wasn't until we gave him Ativan that he stopped doing it, actually. So Ativan will actually make someone who has excitatory catatonia more relaxed and calm. Ativan will make someone who has stuporous catatonia move more normally, right? But they can always cycle back and forth. So be careful. Someone who has stuporous catatonia, 1 second, all of us might have excitatory catatonia. So you just have to know. So we do something called a what? What's the catatonia rating scale that we use? The Bush-Francis catatonia rating scale. Bush-Francis. Right, you'll learn more about this when you guys go to 517 about the scales and stuff. But Bush-Francis catatonia scale for catatonia. The Barnes akathisia rating scale for akathisia. Ames abnormal involuntary movement scale for tardive dyskinesia. All right. What you mentioned, Robert, if someone's having stiffness and it's not catatonia and they're having like Parkinson's stiffness, which can look like that too, it's called cogwheeling, where you move their arm. Yes, you would give them anticholinergic meds, it would work. And sometimes you can't, it's hard to tell. But if someone has other symptoms besides the stiffness, like flat affect, selective mutism, right? Not blinking, you will probably rule out catatonia first and give them a benzo. All right. Be careful of benzos with patients who are, older, geriatric patients or anticholinergics because it can make them delirious, right? Anticholinergics and GABA increasing can cause delirium.
Is there, like, how would you differentiate between the excitation, catatonia, and like agitation? Like when you're
Hard, yeah. Agitation, it's usually goal directed, right? I'm mad because I'm in the hospital and I can't get out of here. I'm mad because my wife is forcing me to do a psyche eval and I don't want to. Discharge me now or I'm gonna hurt you, right? That's agitation. Catatonia is purposeless.
This
They
is
just do
purposeless.
stuff. Yeah, it's not goal directed at all. Doesn't make any sense. Yeah. Which can sometimes happen with schizophrenia too, right? There's, but usually it's in the context of a delusion that they believe something, like a voice is telling me to hurt you, or a voice is telling me to break the stop sign. And sometimes it's hard to tell, So a lot of times, we're guilty of it, but we use polypharmacy because we have to kind of rule things out and see how is he responding. If I'm giving him a D2 blocker because I think that it's a delusion, it's not doing anything, then possibly it could be something else, right? So we would try something else. So, observation skills and seeing what's happening. Yeah. Because too much dopamine blockade can cause drug-induced Parkinsonism, which can look like catatonia, right? This person just got 20 milligrams of Haldol in the past 2 hours. Now they're stiff and they're laying in bed all day. It's probably, and they have no history of catatonia. It's probably EPS. So I'd probably give them anticholinergic first. Give them like, Cogentin IM or Haldol or Benadryl IM and see what happens. No metabolic syndrome. Metabolic syndrome is a group of symptoms that someone can have which puts them at risk for developing diabetes, right? Or cardiac problems. So the mnemonic I like to use is PHATS, PHATS, which I'm going to show you guys. Let me share my screen. Can you guys see risk factors of metabolic syndrome? All right. So someone has elevated blood pressure, right? Someone's HDL is low, it should be higher. Someone's bad cholesterol, triglycerides is high. They have fat where you shouldn't, the abdomen, abdominal fat's no good, right? They have a fasting blood glucose that's very high, that's above 120. And they have insulin resistance. So insulin resistance, we can tell from, elevated triglycerides. It's a cheap way to check if they're going to develop insulin resistance. So fats, PHATS. P stands for pressure, elevated blood pressure. H stands for HDL, which is going to be low. A stands for abdomen or adipose, right? Abdomen fat. T stands for triglyceride, which is going to be elevated, right? And S stands for sugar. So if you don't remember these things from this diagram, there's no fats. PHATS. Those are the risk factors for metabolic syndrome. All right. Any questions with that? EPS, these are the symptoms: pseudo-Parkinsonism, right? Or drug-induced Parkinsonism, acute dystonia, you might see some grimacing, involuntary eye movement, which is called ocular gyrocrisis, where their eyes kind of stay up. The most dangerous one is called laryngeal spasms because they'll choke on their food. You've had that as a medical emergency in the hospital. Someone was eating breakfast and they were having laryngeal spasms. We had to do CPR and we had to use the suction to get the food out of their mouth. Akathisia, restlessness. They have trouble standing still. They're pacing around, right? Sometimes the patient might seem aggressive and the doctor will be like, hey, let's give them Haldol 5 because they're trying to leave the unit, right? You give them a Haldol 5 and they're still pacing around. Doctor says, give them Haldol 5 again. No, it might not be that they're agitated. It might be they're having akathisia. Give them, you can give them a beta blocker if they're willing to take it by mouth, or a benzo, right? That'll help. So the 3 treatments for akathisia are benzodiazepines, which I would reserve as second line, beta blockers like propranolol, or mirtazapine, which I use a lot, mirtazapine, for akathisia. When would you not use mirtazapine? If a patient has a comorbidity of what? Bipolarity or schizoaffective disorder, right? Because remember, mirtazapine is serotonergic. So if someone is schizoaffective and has mania in the past or depression in the past, and you give them mirtazapine with serotonergic, it can cause them to cycle. So be careful with that, right? So schizoaffective, history of bipolarity, don't give them mirtazapine, all right? Tardive dyskinesia, hypodopaminergic state, they might chew, they might have their tongue movement. The reason why tardive is irreversible usually is because a lot of the symptoms you don't see initially. Because remember, unlike akathisia, which has a sensory component, tardive dyskinesia only has a motor component. So what does that mean? What does that mean? It only has a motor component. There's no sensory component.
They don't feel it, they just do
Yeah,
it.
they don't. Yeah, patients aren't aware of it, right? It's happening this whole time, and they don't know, right? Their wife thought that their husband was flirting with them, but he was moving his tongue because he had tardive dyskinesia. He wasn't flirting with her. You know what I mean? So, or it's happening when the mouth is closed and the tongue is moving. The tongue is moving inside their mouth. They can't tell. So that's why usually what I'll do, I'll say, hey, can you, in camera, if I'm doing telehealth, can you stick your tongue out, say, ah? And you see their tongue start like moving a little bit. And I'll say, hey, do you notice your tongue is moving? Look at yourself on camera. Oh my God, I never noticed that before. I can't even feel it. I didn't know that was happening. But that could be tardive dyskinesia, all right? So the earlier that you treat it, the better the outcomes. What happens is by the time it gets to your face, to your eyes, to your mouth, when it gets very tardive, like you're chewing tar, it's already to a point where it's irreversible. Of course, the VMAT2 inhibitors will reduce it, and sometimes they will kind of, get rid of it. But once you stop the meds, it usually comes back. But if you treat it very minimal, with just the mild tongue movements or the slight jerking of the lips, usually it could be reversible. Could be. Right, these are the 4 dopamine pathways you should know. Right, pathway 1, VTA to nucleus accumbens, is the mesolimbic. Pathway number 2, VTA to the prefrontal cortex, is the mesocortical. Pathway number 3, substantia nigra to the striatum or nigrostriatal. Pathway number 4 is the tuberoinfundibular, right? Hypothalamus to the pituitary gland, all right? So definitely no difference between pharmacokinetic interactions, pharmacodynamic, no upregulation, downregulation, know the clinical profiles of specific medications, right? Which meds cause more weight gain, which meds cause less sexual side effects. Let's go back to depression. If someone is, I don't know, a college student, right? And they have depression for the first time. They don't want to gain weight. And of course, they don't want sexual dysfunction. White might be a good option for them.
Wellbutrin.
Very good, Wellbutrin. Assuming they don't have a history of what?
Seizures.
Very good, right? That's it.
Mhm.
Someone has an eating disorder and also has comorbid bipolar mania and is put on carbamazepine. What would you be on the lookout for? Checking Chem 20. What electrolyte would you look out for? Because carbamazepine can cause what? Low sodium, hyponatremia. All right. If someone has an eating disorder or a history of eating disorder and they're purging, hyponatremia can cause seizures. All right. So be careful with that. So I'm not just going to ask you like questions. What is it? You have to apply these, you have to understand these concepts and they're going to be clinical based, right? Patient has this and this. What will be the best option? All right. Patient has this. Why would you not choose that? Right. Mechanisms of action. Definitely know what D2 antagonism can do. Know what 5-HT2A antagonism can do. Know what a 5-HT1A partial agonist does. Know what antihistamine, anticholinergic does. Right. Right. Know what alpha blockade can do. Alpha blocker, right? Suppresses the parasympathetic, the sympathetic response. Therefore, it's good for anxiety and trauma. Know the treatments for the side effects of meds. Know the treatments for dystonia. Know the treatments for tardive dyskinesia. Know the treatments for akathisia. Know the blood levels of lithium, Depakote, carbamazepine, clozapine. Know what happens if someone tries to overdose on D2 medications, right? Because we will have patients try to overdose on their meds. Know what the signs and symptoms are of NMS, neuroleptic malignant syndrome, right? Know how to distinguish NMS from serotonin syndrome. If someone comes to the ER and you're working the ER and someone overdosed on their whole bottle of Prozac, right? They're at risk for serotonin syndrome. Know what the symptoms are, right? Serotonin usually has hyperreflexia, clonus, hyperthermia, right? Change in cognitive functioning, which can look like NMS, but the difference with NMS is since you're blocking dopamine, they're going to be stiff like a board. They're going to have elevated CPK because they're muscle breaking. The muscles are constantly staying stiff, right? CPK is going to go up and they're going to be at risk for rhabdomyolysis, all right? All right, so we'll spend the next half hour answering any questions that you guys have about the midterm. Right? Obviously, I can't tell you exactly what's on the test, but I probably gave you like 60% just from what we talked about just now. And the rest is going to be from your readings. Know the half-lives, know which SSRI has the longest half-life, which is Prozac. Know which SSRI has the shortest half-life, which is paroxetine. Know the distinguishing factors between them. Like I said, Paxil is more antihistamine, anticholinergic, so it can cause more, weight gain, more confusion, worse withdrawal symptoms. SNRIs like Effexor, duloxetine, right? Know that they're also used for neuropathic pain. Know that you should be checking liver functioning when you're giving someone SNRIs, so it can cause spontaneous liver injury. Know what the inhibitors are, right? Inhibitors, BFP, bupropion, fluoxetine, paroxetine, those inhibit CYP enzymes, therefore they might raise levels of other meds. Know inducers like St. John's wort. Chamomile tea is an inhibitor, so someone drinks chamomile tea, that might increase the level of their medications. If someone's afraid of metabolic side effects from, remember I mentioned what 3 antipsychotics are notorious for causing weight gain? The peens, which ones?
Olanzapine, the
Quetiapine,
I think, okay.
and clozapine, right? What can you do prophylactically if they're afraid of weight? What's the most evidence-based? You can prescribe something.
Metformin.
Very good, metformin, right? So that's evidence-based, and I do that on a pretty regular basis. You start metformin, you try to push it up to 2 grams a day. It might take 3 months to get there, but I'll do 500 milligrams once a day, then 500 milligrams twice a day, 1,500, then 1,000 twice a day. Try to max it out at 2 grams. I would go slow because if you go too fast and they have diarrhea and nausea and vomiting, they're probably going to stop treatment. So just go very slow and just let them know that our goal is to reach 2 grams a day of metformin to get the best evidence out of it. You're better off starting metformin prophylactically than waiting until they put on 20 pounds. I've seen people put on 120 pounds in olanzapine, 120 pounds. The person was 130 when they came to me, 5'8", very skinny. Now they're like 250. or more. Yeah, so be careful with that, because weight gain could be an issue. And you know, these are chronic disorders, so you want to make sure that patients can stay on these meds lifelong, right, if they have to. So make sure that you get them on a good dose and you manage those side effects right away. Obviously, healthy diet and exercise would also be part of that, right? Referral to a nutritionist, follow up with their PCP. I've had a few PCPs I've had fights with on the phone because they would discontinue the metformin because they say, oh, you don't have diabetes. Why is your psychiatrist giving you metformin? I have to like educate them. No, I know they don't have diabetes. It's because, you know, the olanzapine can cause weight gain, and this is evidence-based. Here's the study to show you, right? But it'll happen. And the family will say, hey, why are you putting my son on metformin? The pediatrician said that they didn't need that. They don't have diabetes. And you have to educate them, fortunately. Happens a lot. What can happen with long-term metformin use? Metformin interferes with what metabolism? It can affect something. So someone who has metformin can develop depression or anxiety over time. Why? It suppresses what? B12 and folate. All right. So over time, someone's on metformin, make sure you check B12 and folate levels. All right. Or supplement it. Speaking of lithium, lithium will also cause hypothyroidism. So if someone's on long-term lithium and they start developing very bad depression, I would check a TSH. See how I'm giving you guys clinical pearls, because these are mistakes that people make and it can cause polypharmacy for no reason, right? Someone who has, you know, is on metformin and olanzapine, the person who's prescribed metformin isn't aware that metformin can depress B12 and folate. The person starts developing depression, anxiety, and they get put on an SSRI, right? Polypharmacy for no reason. And they get put in a benzo, now they're having panic attack. Polypharmacy for no reason. So please do a level. Please, you know, check B12 folate and make sure that the patient's not having, you know, secondary side effects. What happens is people get secondary side effects from the meds we're prescribing them. We're giving them more meds, and then we keep adding more meds, and people end up on 5 or 6 meds, and when in reality, they only really need one with good monitoring. Okay. Who is at risk for developing B12 and folate deficiency? People who are what?
Vegans.
Vegans, right? Yeah, because no eggs, no meats. They don't really get that. Yeah. So what's the moral of the story? Don't be a vegan. You can be vegan, but I'm just gonna check you more often. I know it's a lot, but if you watch all my videos, it's not just a plug for me to get more views on my YouTube, but it's a lot of material, so just watch it. And during the semester, everyone's asking me different questions, you know. Even though I'm writing these questions from scratch, some of them have the same questions from the other semesters. I just reworded them, and you know, they might have different criteria, but for the most part, you'll be okay. The test is more application of knowledge. All right, there is going to be some definitions. We have like the pathways, but you know, understand how does a neuron adapt when you give them certain treatments. Partial agonists, all right, know about partial agonists like Abilify, brexpiprazole, cariprazine. Those are the 3 partial agonists. Aripiprazole, brexpiprazole, cariprazine are partial agonists. All right. In the presence of a full agonist, a partial agonist will work as a net antagonist, right? In the presence of not enough agonism, let's say someone's having, I don't know, hyperprolactinemia, right? Not enough dopamine. You give them a partial agonist, it's going to increase the dose of dopamine. That's why we call them stabilizers sometimes. Some books also call them 3rd generation antipsychotics, right? The 1st generation would be the strong D2 blockers. 2nd generation would be the 5-HT2A antagonist and the 5-HT1A partial agonist. The 3rd generation, if you want to call it that, would be partial agonists, right? Because they stabilize. Any questions?
At the very beginning of the lecture, you kind of started talking about the difference, how you would tell the difference between early activation versus hypomania.
Yes.
And then I think we went off on a different
yeah.
topic.
So early activation can come out as irritability, increased anxiety, All right, irritability, increased anxiety usually happens a lot with children, adolescents. But be careful if they start not sleeping, they start being very angry, little things get them angry, they start being a little grandiose, they start saying things like, I know more than my teacher, or they start reckless spending or risky sexual behavior. That might be more than activation. That might be a hypomanic episode. All right, so it's hard to tell the difference sometimes. It's from family history and the severity of the other symptoms that are there. If it's just irritability, increased anxiety, it's probably early activation and they're sleeping. Or they're not sleeping, but then they're exhausted in the morning, all right? But if you give them an SSRI and they're not sleeping and they're still going through the whole day like everything's fine, you probably triggered a hypomanic episode. Which happened to one of my private patients actually a couple of days ago. I put him on fluoxetine and we added, I added Abilify, but mom said, because mom was saying that initially the fluoxetine was working. And then when I said, can you explain what working means to me? It means he has more energy. Is he sleeping? No, he's actually not sleeping. Is he angry? Yes, he's angry. So why just tell me he was better? No, it's actually not better. I'm sorry. I just meant that he was more creative. Okay, I'm sorry. I might have made him manic. Let's bring it back down. So I stopped the fluoxetine, which takes 2 to 4 weeks to wash out, right? So that's the sad part. So I might have to raise the Abilify to balance it out to give more mood stabilization, while the long half-life fluoxetine takes about a month to wash out. That's more of the science and the art, more the art, I'm sorry, of psychopharmacology, right? Understanding what's happening and how to adjust the medicine.
Can you just go over the 5-HT2A agonist and the D2 partial agonist again?
Yes. So 5-HT2A antagonist downstream will actually increase dopamine in the nigrostriatal pathway and the mesocortical pathway. That's why when they created that medication, they were saying initially, which was disproven, it would improve negative symptoms and have zero risk of EPS, right? Much less risk because of the 5-HT2A, but it's not zero risk. So if you give someone a 5-HT2A antagonist like olanzapine or low-dose risperidone or Latuda, lorazepam, right? They are at less risk of developing dystonia because you're giving a little bit of dopamine from that 5-HT2A antagonist in the nigrostriatal pathway, and less likelihood of causing drug-induced Parkinsonism of mask-like facies because you're giving a little bit of dopamine in the mesocortical pathway. Does that make sense? 5-HT2A antagonism is synonymous with 5-HT1A partial agonist. They're like the yin and yang of each other. So agonizing 5-HT2A is the same as agonizing 5-HT1A, if that makes sense. So you give someone it's the opposite of 5-HT1A. I'm sorry. Agonizing 5-HT1A does the opposite of agonizing 5-HT1A. That's why when we say you give someone a 5-HT2A, it does the same as giving someone a 5-HT1A partial agonist, right? So 5-HT2A antagonist is the same as giving someone a 5-HT1A partial agonist. Does that make sense? So atypicals usually have both. So it's interesting. You only have a few atypicals, olanzapine, quetiapine, clozapine, that are both 5-HT2A antagonists and 5-HT1A partial agonists. And guess what? Those three meds have the least risk of developing tardive dyskinesia and drug-induced Parkinsonism. Olanzapine, quetiapine, and clozapine have the least risk of causing drug-induced Parkinsonism, dystonia, and tardive dyskinesia. It's possible because they're both 5-HT2A antagonists and 5-HT1A partial agonists, which both together increase dopamine in the nigrostriatal pathway and the dorsolateral prefrontal cortex, mesocortical pathway. All right. I don't think it's a coincidence. And you asked about partial agonists. So partial agonists only give a little bit of antagonism, right? So since I am a specialist in schizophrenia, I'm going to go into detail about how to use partial agonists. I think it's an art form that people sometimes don't learn and don't know how to use effectively. Abilify, aripiprazole, which is a D2 partial agonist, right? So when you give someone a D2 antagonist, what percentage of dopamine receptors in the mesolimbic area do you think you have to block for there to be an antipsychotic effect? How many percent? 100%, 90%?
60 to 80.
Yeah, between 60 and 80%, right? Give or take. That's what the stop book says, right? So when they do PET scans, they'll see that, that much of dopamine blockade works. What happens is we don't know, because obviously schizophrenia is a spectrum. There's someone that might need 100% dopamine blockade to have full remission. Someone might only need 60% dopamine blockade for full remission. Remember, 80% is also the cutoff in the nigrostriatal pathway to cause EPS, right? So imagine someone needs 80% of dopamine blockade for antipsychotic effect, right? They're probably at highest risk of developing dystonia, because when you give someone a medication like Haldol, you're going to block 80% in the mesolimbic, but the med can't tell the difference. It's probably going to block 80% in both pathways. So if you give someone 80% blockade in mesolimbic and you give someone 80% blockade in nigrostriatal, sure, they won't have psychosis, but they're also going to be stiff like a board, right? So those are the patients you might have to give cogentin to kind of balance it out a little bit, all right? Now, if a patient is lucky and all they need is 65% dopamine blockade, right? In the mesolimbic area, you might be able to give them 65% dopamine blockade with, I don't know, 2 milligrams of Haldol and not block more than 65% nigrostriatal. They don't have EPS. Those are the patients that are lucky, that are able to get symptom remission without the side effects, right? But I can't do a test to figure out how much blockade I need to give a patient, right? And there are some patients that are non-responsive to dopamine blockade. Those are the patients that we consider treatment-resistant schizophrenia and might have to give them clozapine, right? Because clozapine's mechanism has nothing to do with dopamine blockade, because it only blocks like 40 to 60% dopamine receptors, right? Its mechanism is unknown, or it's probably due to TAR1 agonism or cholinergic agonism, which I'll talk about, some other time, right? Because I'm not going to test about that. So know that clozapine does not work on dopamine blockade. It has another mechanism, all right? So that's why it might work for treatment-resistant schizophrenia, because that schizophrenia is not responsive to dopamine blockade. Now, the reason why I talk about partial agonism is because Abilify at its highest dose, let's say 20 to 30 milligrams a day, saturate all dopamine receptors, can only block up to 75% of dopamine activity. All right. So that means that if you block 70% dopamine activity, you're getting 25% intrinsic activity of dopamine. So what does that mean? That means that if someone needs 80% of dopamine blockade, Abilify is not going to work, because at max dose, saturating all your receptors, you're only going to get 75%. All right, so don't try Abilify. What a pet peeve of mine is when, I look at people's charts and I see, well, they tried risperidone, they tried olanzapine, which can actually get 100% dopamine blockade. Patient still doesn't have response to the medication. The other provider doesn't want to try clozapine because they're afraid of the blood work or they're afraid of the side effects, and they put the patient on Abilify and the patient becomes worse. That makes no sense. That's like someone for pain management has taken Percocets, has taken opioids. Now you say, no problem, just take aspirin for your pain, you'll be all right? Obviously, it's not going to work. So once someone's tasted the strong dopamine blockade, you can't go back to Abilify. And people make that mistake, and people become aggressive, they become more psychotic. So what you want to do is you want to climb up the ladder, right? Sometimes I'll do Abilify early on in treatment. Let's maximize Abilify, because I know if I give you an injectable, 400 milligrams of Abilify Maintainer, I know you're taking it, I'm saturating all your dopamine receptors. We're already blocking 75%, all right? If that doesn't work, then maybe we'll try risperidone and I'll push it up on an vagus extender, which is long-acting injectable, and we'll try to get 100% dopamine blockade. If that doesn't work, I've already ruled out that dopamine blockade is going to help you with your psychosis. I should put you on clozapine as that third trial. Does that make sense?
Mhm.
Because if you don't practice that way, people get put on many meds and it's trial and error. No one understands what they're doing, and patients are suffering. So that's why, like, when people come to me, I do a thorough history, I do plasma drug levels, and I make sure I start clozapine right away, or we don't mix and match meds that people have tried already. Like, it makes no sense to put someone on risperidone, olanzapine, Haldol, Prolixin, right? Those are the four trials. They're all dopamine blockers. What's the difference? Not unless someone is like a fast metabolizer, right? A 2D6 and one med is not working as a 2D6 substrate, and they really need a 3A4 medication, then it makes sense. But if it's not a pharmacokinetic issue, you should really do clozapine right away. And sometimes with clozapine, I add other meds. So I have patients on clozapine and a partial agonist because they don't compete. Remember, clozapine does antipsychotic effects not based on dopamine. So I can give them a partial agonist like Abilify if needed. And I can give them a strong dopamine blocker like Prolixin or Haldol on top of it. And they're not going to compete with each other. Questions? Don't worry. When you guys get to 517, 27, I'll go into so much more detail than this. But this is just the tip of the iceberg. I don't want to confuse you now. So when it comes to the partial agonists, they're all not equal. So if you go from the most activating, which is Abilify, because remember, it gives about 25% of dopamine back, so you only block up to 75%, to Vraylar, which is cariprazine, which blocks about 81% and gives 19%, to brexpiprazole, which is around 83 to 85%. Get it? So if you want to climb up the ladder and really see how much dopamine blockade it takes for patients to get effect. The only reason why, ideally, I would want to do that with patients, right? To be the most scientific and really put them through. But most patients want relief of their psychosis, that they don't want to try the step-by-step approach of going from all 3 partial agonists to a full D2 blocker. Usually for the patient's sake, I'll say, okay, you know what? Let's just go to a dopamine blocker and see if it works. If it doesn't, we'll go right to clozapine. But, in theory, if the patient wasn't suffering from the tormenting symptoms of voices telling them that they're terrible, I would try to climb up Abilify to Vraylar, cariprazine, to brexpiprazole, to probably risperidone, to olanzapine, and then, clozapine obviously if needed. It's going up the ladder of, medications of dopamine blockade. The medication that caused the least amount of weight gain is actually lorazepam and Geodon. Ziprasidone and lorazepam cause the least amount of weight gain. Ziprasidone and lorazepam, which is Latuda or Geodon. So if a patient is already obese, has a family history of, metabolic symptoms or diabetes, I would probably put them on Latuda, lorazepam, as an option. The only downside to lorazepam is a caloric requirement. They need to take 350 calories within a half hour before taking the meds. Because if not, they don't get full absorption. If they take Latuda on an empty stomach, you only absorb half of it.
What's the other one with a caloric requirement?
Ziprasidone, Geodon.
Okay, so they both have it. Okay, yeah.
Ziprasidone. Lorazepam is actually synthesized from ziprasidone. They're related. Very interesting. I recently got in. I'm such a nerd. I got into stereo. You guys know what stereochemistry is from organic chemistry? Stereochemistry means they draw out the molecule of the medication, and by looking at the connections of what it is, you can actually tell what side effects the meds are. So I want you guys to look at the stereochemistry. Look at clozapine and look at olanzapine and look at chlorpromazine, the way it's drawn out. And you'll see that based on the stereochemistry of it, or the molecule, they actually have the way the molecule rings are is tricyclic in nature. They have very strong anticholinergic, antihistamine properties. So even though technically they're different, one is a first generation and the other two are second generations, their side effects are very similar, right? So you can't just make a blanket statement that one is a second generation, doesn't cause a lot of weight gain, because chlorpromazine can cause a lot of weight gain too. It's anticholinergic, antihistamine. But technically it's a first generation antipsychotic. So I wouldn't give that as a first generation to someone who already has like obesity or any issues, right? Chlorpromazine is used a lot in kids, especially in very violent kids, because it's a very strong alpha blocker. So it blocks their fight or flight response when they're aggressive, but also causes them at risk for orthostasis, right? So they can fall down and hit their head. So we try not to use Thorazine a lot. If you IM the Thorazine and they change position, they faint, that could be a big issue in the hospital. So we try our best not to use Thorazine anymore. But it works pretty quickly, actually.
Could you give it at night then, like you do with tamsulosin?
Yeah, I tend to dose all my antipsychotics at night, like I said, because your nigrostriatal pathway is not active unless you're a cab driver or an exotic dancer. You should be asleep at night, right? So you want it to peak, peak when they're sleeping, because when it peaks, they're not going to have that side effect. And a lot of times, EPS is transient. So dystonia, akathisia, that's transient. So you don't want to keep someone on long-term benztropine. After maybe 6 months to a year, I would try to wean off the benztropine. Let's say if someone's on risperidone 3 milligrams a day, right? And that by itself is causing them to be a little stiff, and you notice that their movement's a little bit slower. I would probably start with benztropine 1 milligram in the morning only, and see if it gives coverage for the whole day. If that doesn't work, then I'll do 1 milligram twice a day, right, to give them coverage for the whole day. After about 6 months to a year, I'll go to 1 milligram or 0.5 twice a day and see if the movements get better. If it isn't, I'll wean them off. Because a lot of times you can challenge them off the anticholinergic and they go up. People just, they get on it and people just don't want to change it. Like the other providers don't want to change it, but you could. Because remember, long-term anticholinergics have been linked to tardive dyskinesia. Also beta blockers, right? I mean, Akathisia too. You want to get people off it because usually about 6 months to a year, people will adapt to the akathisia. You can wean them off the beta blockers and see. You use that saying, usually what gets you well is higher than what keeps you well, right? What gets you well is higher than what keeps you well. So maintenance treatment tends to be lower. So during an acute manic episode, you might have to go a little higher, right? You might have to push lithium up to, I don't know, 1.1, right? To stabilize the mania. Once you're in a maintenance treatment and you haven't had any more breakthrough manias, I might reduce lithium to, I don't know, 0.6, 0.75, which is recommended, right? CANMAT guidelines, Canadian and Mood Disorder Anxiety Treatment Guidelines. CANMAT is what I follow because I really like the way they have it written down. And they recommend keeping a maintenance dose of lithium between 0.6 and 0.75. Because number one, less risk of lithium toxicity and it preserves your kidney function, right? Kidney function is impaired if you keep people on lithium dose of 0.8 higher for long periods of time. Unless they're acutely manic, or they really need the 0.8, right? Also, interactions with lithium, NSAIDs, calcium channel blockers, angiotensin receptor blockers, some diuretics will increase lithium level, all right, to know that. Caffeine will reduce lithium levels. Someone drinks coffee, they're going to pee it out, lithium levels are going to drop, right? High sodium diet is going to drop lithium levels. Low sodium diet is going to increase lithium because your body's going to absorb lithium, right? Your body can't tell the difference between NaCl, which is sodium chloride, or LiCl, which is lithium chloride. It's indistinguishable. They can't tell the difference. Once someone's stable, I usually do a lithium level every 6 months. In the beginning, I usually do it after I get them to a decent dose. Once I find a dose that they're stable on, I'll do a level there. Then maybe a month down the line, just in case. And once they're stable on it for 6 months, I just do it every 6 months. Unless there's like a change in their diet or they want to become a marathon runner all of a sudden, right? And I want to make sure that they're not dehydrating. I have to adjust it. The lithium should be dosed once at bedtime to preserve kidney function. Once at bedtime, once you find a good dose. Lithium, check kidney functioning, check thyroid, right? It can cause leukocytosis. You want to make sure you check a CBC. So you want to make sure they don't have elevated white blood cells already before that. So if they go to their primary care, they don't freak out and say, hey, you have an infection. No, I'm just on lithium. Advanced tip. I actually have a patient on clozapine and they kept developing slightly low neutropenia. And since they had a mood disorder, they have schizoaffective, so I added lithium to balance it out. So I'm using the lithium side effect, which increases white blood cell count, to help them stay on clozapine, right? That's a black belt level tip, but it's all right. You guys will get there. So you use the side effects of the meds to your advantage. Right, so if a patient has depression and their issues are insomnia, give them a sedating antidepressant. Right, if someone has issues with energy, give them a more stimulating antidepressant. If someone has issues with adherence, give them a medicine that has a long half-life. Got 10 minutes. I know we covered a lot today, but you can watch this video again if you want. If someone develops hypothyroidism and lithium, would you stop the lithium?
Just give them
No.
Synthroid.
Right? Yeah, keep them on lithium and give them Synthroid. If someone develops agranulocytosis on the clozapine, would you be able to re-challenge them on clozapine again in the future?
Would you be able to what? Sorry.
Re-challenge them on clozapine again in the future if they had to, if you had to stop it because of severe neutropenia. What do you think?
Probably not, right? The reaction might get even worse in the future.
No, you would actually. The
Oh,
guidelines
you would?
challenge them. Yeah, but with a much slower titration, followed with a with an internist or someone to manage it. Yeah, because the clozapine is the only med that's been helping them with the treatment-resistant schizophrenia. There's no other options. It's a risk versus might have to. Yeah, even with myocarditis, you just have to go slower. with more frequent monitoring. You would. Yeah. Now remember, I mentioned before, clozapine is a very strong anticholinergic. So if someone's on clozapine 400 milligrams, right, now they start developing myocarditis, would it be smart just to stop the clozapine cold turkey?
Mhm.
Because they'll have rebound. They'll have cholinergic withdrawal, right? They'll have rebound agitation and delirium. You would substitute the clozapine with an equivalent dose of cogentin, right? Which is give or take 1 milligram of cogentin for 50 milligrams of Benadryl per 50 milligrams of clozapine. If they're a smoker, it's 100 milligrams of clozapine. I'm not testing you on this titrate. This is more advanced, but just know that you have to substitute it. So if someone's a smoker, right, it would be 100 milligrams of clozapine per 1 milligram of cogentin per 50 milligrams of Benadryl. If they're a non-smoker, it would be 50 milligrams of clozapine to 50 milligrams of Benadryl to 1 milligram of cogentin, right? Because if they're not smoking, they're not inducing their 1A2. But the key is just you're replacing the cholinergic receptors with something that's not clozapine, because you need those receptors to downregulate again. To upregulate, I'm sorry, to upregulate again. They're downregulated from the clozapine. It's anticholinergic. You're giving your body, which takes about, a month or so to rebound. So you have to do a very slow taper. Put them on with the equivalent dose of, clozapine if it's 400 milligrams, and then wean them off that other anticholinergic, whether it's Benadryl or cogentin, and reduce it by 25% per week till you get them off. Except if they have QTC prolongation, then more messy. You'll probably have to do that in patient, but see the different factors, you just have to understand how the meds work. But
You could prophylactically get them on magnesium supplements too for QT prolongation.
could, yeah. But I mean, if you're just doing psych, then I would probably just, I don't know. But if you're on a practicing in a rural area and there was no one else but you, then I guess you would do all that yourself. I'm sure they'll have to pay you a lot of money though. Any other questions? So for the test, if more than 50% of you guys get a question wrong, I usually throw it out. We don't curve. All right, we just throw it. So the way it works is that I'd say, I don't know, question number 5, 50% of you guys get it wrong. I throw the question out, whoever got it wrong will get that extra 2 points. But the problem is if you got it right, you don't get anything. All right, so that's how there's no curve. We're not allowed to curve, but we throw questions out and, get some people, well, you curved. Some people got 10 points. I only got 4. Well, unfortunately, you only got 4 because the questions we threw out, you got right already. So that's how it works. Any other questions?
And the test is open from midnight Sunday to midnight Monday?
24 hours. Yep, that's correct.
Okay.
If you're feeling adventurous, I dare you to do it at 11 p.m., an hour before it closes. If you're feeling adventurous, I'd be very impressed. I'll probably give you an extra couple points if you do that. No, I can't.
Then everyone's gonna do it.
How many questions is it?
50.
Okay.
2 points each. Yeah, 50. Every question I've touched on the topic, during this lecture or the other one. So I'll just say that there's no curveballs. I'm very fair. I'm not trying to fail anybody here intentionally. I just want you guys to understand the concepts enough that you'll be able to prescribe and practice safely, right? So if you know the pathway, that's an extra 10 points there. I think there's 5 questions in that alone. I know the dopamine pathways. No upregulation, downregulation. That's another 4 points, right? I'm kind of giving you a hint. Know the inhibitors. That's another point. Know which meds cause more weight gain, other ones that are weight neutral. That's probably another, 5. That's 20 points I gave you already. Know what will affect lithium levels? What will affect clozapine? Smoking, what is it going to do? Reduce clozapine levels. Drinking caffeine, increase clozapine levels. Drinking caffeine, decrease lithium levels. All right. All right, everybody. Well, good luck. If you have any other questions, just email me. All right. And, watch my videos later. Take care.
Thank you.
Thanks so much.
Yep.